Good evening. I'm going to be presenting a patient who was seen as a GI consult, which is the service that I am currently rounding with right now for my clinical time. The patient that we had was a 62-year-old male with a past medical history that was significant for hypertension and diabetes. He presented to the ER the day before with a complaint of palpitations that he had had for a couple of days. He was actually seen in our ER the day before with similar complaints, and he was found to be an SVT, and he was converted to sinus rhythm with adenosine. He was also found to have anemia, a liver injury as indicated by elevated LFTs, a renal injury which was indicated by elevated BUN and creatinine, but he had decided to sign out AMA actually because he was a cattle rancher and he needed to take care of some personal matters at his cattle ranch. However, he came back again the next day, again complaining about the palpitations. He was found to again be an SVT, so he was converted back to sinus rhythm again with adenosine. But now he was also in acute liver failure. His LFTs were even more elevated than they were the day before. He also had worsening renal function, and now he was also presenting with lactic acidosis, and his lactic level was actually 14.4. Pretty crazy. He also continued to be anemic. His hemoglobin was 6.4. But he denied any fever, chills, nausea, or vomiting. He also denies smoking, alcohol, or drug use. He denies taking any medications at that time. He states that he doesn't like doctors, he's non-compliant with his medications. He doesn't go see a PCP. He takes an aspirin once every few weeks. He was started on a bicarb infusion. He was transfused with 2 units of PRBCs and was admitted to the ICU for further workup, which included imaging and an acute hepatitis panel. The GI service was consulted to evaluate for possible acute liver failure. An abdominal ultrasound was done, which showed hepatomegaly and mild perihepatic ascites. A renal ultrasound was also done, which was unremarkable. And also an abdominal Doppler was done, which showed a normal liver Doppler. He denies seeing any dark blood or stool, dark blood in his stool, or any black tarry stools. He denies using any NSAIDs. He denies any recent weight loss or changes in his appetite. He's never had a colonoscopy in his life, and he did not show any improvement in his hemoglobin with the blood transfusion that he had had before. His hemoglobin remained at 6.5. So a hemolysis workup was also initiated, and another unit of PRBCs was ordered. An occult stool study was also ordered, as well as a CT of his abdomen. The CT of his abdomen showed cecal wall thickening with differential considerations for infection, inflammatory colitis, or neoplasm. The patient was also very coagulopathic with a PTT of 20 and an INR of 1.8. So vitamin K was also ordered to correct his coagulopathy. Upon further questioning of this patient, he did reveal that he had, in fact, a pretty significant family history for colon cancer. His father actually died of colon cancer in his 80s, and his older sister was actually diagnosed with colon cancer in her 30s, which resulted in a total colectomy. Given this new information and the CT findings, plus also not finding a definite source of bleeding to explain his anemia, the patient was scheduled for an EGD and a colonoscopy. Luckily, the next day, the patient did show improvement in his hemoglobin. He corrected to 7.7. His hepatitis panel came back negative. His LFTs were starting to trend down. His BUN and creatinine were also improved. His lactic acidosis had corrected, and his lactate level was now 2. So it was determined that his acute kidney injury and the acute liver failure were most likely due to a shock liver from low perfusion while he was in SVT for such a long time. So we proceeded with the EGD and colonoscopy. The EGD was normal. However, the colonoscopy did find a large ulcerated cecal mass. Multiple biopsies were taken with a high probability for colon cancer. The general surgery team was then consulted, and the patient was scheduled for a surgical resection. Unfortunately, the night before, the patient went back into SVT again before his surgery. So again, he was converted with adenosine and then was started on cardizem. The next morning, his heart rate stayed stable, so they proceeded with the right hemicolectomy, and the specimens were sent for staging. His labs continued to improve. He didn't show any further episodes of SVT over the subsequent days that he was admitted. And so the patient was then discharged with instructions to follow up with the general surgery team to discuss his pathology results. Also, of course, a follow-up with cardiology, and he will need his next colonoscopy in 3 years. I just thought this patient was very interesting because he initially came in for a cardiac issue, which then led to an acute liver injury, which then led to a GI consult, which then subsequently led to the findings of his colon cancer. If he had never had this episode of SVT, perhaps his colon cancer would have gone undiagnosed since the patient didn't have the typical signs of colon cancer, such as bloody stool, weight loss, or any changes in his appetite, and he didn't like going to doctors. So this patient was really very lucky, and it was pretty awesome to be a part of his outcome because, we were able to do the resection, and now he's cancer-free, and as long as his biopsies don't show that he's in his lymph nodes, we'll have to wait for those results. But it was just pretty lucky that he ended up coming into the ER and we were able to find his colon cancer. So just a pretty cool case. So hope y'all appreciate it. Thanks.